Welcome to this custom deep dive. Today, we are opening up just a fascinating stack of medical and nursing sources that are entirely focused on blood pressure.
Yeah, it's a topic everyone thinks they know, right?
Exactly. I mean, the mission for this deep dive is to really get past that simple, 120/80 headline. We want to uncover the hidden story of perfusion and, well, look at the surprisingly brutal history of how we even figured out blood pressure exists in the first
Oh
place.
yeah, the history it's pretty wild.
It is. And we're also going to get into why the most common measurement mistakes, which are happening like every single day, can completely change a medical diagnosis practically overnight.
Which is terrifying when you really think about it.
Right, because when you go to the doctor, that there's just a few things you always expect to happen. You sit on that crinkly paper, someone wraps a Velcro cuff around your arm, it inflates until it's just, slightly uncomfortable.
Yep, the classic arm squeeze.
Right. And then a machine or sometimes a person with a stethoscope just spits out two numbers. I mean, we get our blood pressure checked at almost every single medical encounter.
We do. It is really the ultimate medical baseline. I mean, it's so ubiquitous in healthcare that we tend to treat those two numbers like they're handed down on stone tablets or something.
Yeah, like an absolute truth.
Exactly. Like you are either 120/80 and you
Okay.
are fine, or you have a problem. But the sources highlight that blood pressure is not it's just not a single true number. It's this incredibly dynamic, constantly shifting equation.
Right.
So before we can even begin to talk about what a bad blood pressure is, we really have to understand the physical mechanics of what the body is, like actively attempting to achieve every single second of your life.
So let's break that down to first principles because the sources are actually very specific about what those two famous numbers physically represent.
Yeah, so fundamentally, blood pressure is simply the physical force that your circulating blood exerts against the inner walls of your arteries.
Okay, so just literal pressure in a pipe.
Right. It is generated by the heart pumping, and it is modulated by the resistance of your blood vessels. So the top number, your systolic pressure, is the absolute peak pressure in the arteries during ventricular contraction.
Which means?
That is the exact moment when the left ventricle of the heart forcefully ejects blood out into the aorta.
So it's the big squeeze, the absolute maximum force in the system.
Exactly, the big squeeze. And then the bottom number, the diastolic pressure, is the residual pressure that's left in the arteries when the heart relaxes and the chambers are refilling with blood.
Okay, that makes sense.
But to really grasp how this whole system works, we have to look at the foundational equation that governs it. And it's actually very similar to Ohm's law in physics.
Oh, yeah.
Yeah, so blood pressure equals cardiac output multiplied by systemic vascular resistance.
Okay, wait, let me repeat that. Blood pressure equals cardiac output times vascular resistance.
You got it.
So if we visualize this like a city's water supply system, right? The heart is the main water pump. So that's your cardiac output, which is essentially how much water is being pushed out per minute.
Right.
And then the blood vessels are the city's network of pipes. So that's the vascular resistance, meaning like how wide or narrow those pipes actually are.
That is a perfect analogy. So if we follow that water supply idea, anything that changes either the pump's output or the pipe's physical resistance is going to instantly change the pressure in the entire system.
But wait, if the main pump starts failing, or say there's a massive leak somewhere in the city, the water pressure in your house would just drop to zero almost immediately.
Right, in a rigid pipe system, yes.
But the human body obviously doesn't just crash to zero the second something goes wrong. I mean, how does the body compensate for a leak?
Well, it aggressively defends that pressure using these built-in fail-safes. And the sources give a very intense clinical example to illustrate that.
Okay, what is it?
Imagine a trauma patient who is actively hemorrhaging and loses, say, 1.5 liters of blood.
Oh, wow. That's a lot.
It's a massive amount. So because there is significantly less blood volume available to pump, the cardiac output, the pump side of that equation we talked about, drops drastically.
And mechanically, the pressure should just plummet right along with it.
It should. But within literal seconds of that volume dropping, you have these tiny pressure sensors in your body called baroreceptors, and they detect the change.
Baroreceptors, where are those?
They're located primarily in the carotid artery in your neck and in the aortic arch.
The aortic arch, just so I have the anatomy mapped out properly in my head, that is the main, like, curved pipe leaving the very top of the heart, right?
Correct, yeah. So the baroreceptors there sound the alarm to the brain, which immediately triggers the sympathetic nervous system.
The fight or flight system.
Exactly. And the body's response is to massively constrict the peripheral arterioles. So those are the smaller branches of arteries out in your limbs. The body essentially just clamps down on the pipes in your arms and legs, drastically increasing the systemic vascular resistance to make up for all that lost volume.
Oh, I see. The body physically shrinks the container to fit the remaining blood.
It does. It's an incredible survival mechanism.
Yeah.
And this leads to a really crucial takeaway, especially in nursing and emergency medicine.
Which is?
A hemorrhaging patient can actually maintain a completely normal blood pressure reading right up until the exact moment they suddenly collapse.
Wait, really?
Yeah. The compensatory mechanism is so strong that it masks the internal bleeding until the body's reserve is completely exhausted.
So a clinician looking at a monitor could see a totally reassuring 120/80 while the patient is, like, actively in severe life-threatening danger.
Exactly. And this is why trained clinicians do not rely on blood pressure alone. Pressure is really just a means to an end.
Right.
The actual end goal is perfusion, meaning the actual delivery of oxygenated blood to the tissues. Nurses are trained to look for signs of poor perfusion rather than just blindly reading a monitor.
So what are they looking for instead?
They look for a rising heart rate as the pump tries to desperately work faster, or they check for delayed capillary refill.
Capillary refill. That's when a doctor or nurse presses down on your fingernail.
Right,
Yeah.
exactly. Pressing on the nail bed turns it white by forcing the blood out of those tiny capillaries. When you let go, it should pink up again in under 2 seconds.
And if it doesn't?
If it takes longer, or if the patient has cool, really clammy skin,
Yeah.
it means the body is clamping off blood supply to the skin and the extremities to save the oxygen for vital organs like the brain and the heart.
Wow.
Yeah, the perfusion is failing, regardless of what the blood pressure cuff says.
That's fascinating. But if the body's own defense mechanisms can hide what's really going on, accurately measuring that pressure becomes an incredibly high-stakes process.
Highly, highly high stakes, yeah.
And getting that measurement, historically, it was not as simple as just wrapping a Velcro cuff around an arm.
Oh, no, not at all. It
Yeah.
was significantly more invasive.
How invasive are we talking?
Well, the entire concept of actually quantifying this pressure dates back to 1733
Yeah.
with this English clergyman and scientist named Stephen Hales.
Okay.
He wanted to know if blood pressure could actually be measured physically. So he took a live horse, inserted a brass pipe directly into its crural artery, connected that pipe to a glass tube, and literally watched the horse's blood rise more than 8 feet up the column.
Wait, he just stuck a brass pipe into a horse and watched the blood shoot up a 9-foot glass column.
He did.
That is a rather brutal way to run an experiment. I mean, my goodness.
It was definitely brutal. But it proved that the pressure was a measurable physical force that was capable of pushing fluid against gravity.
Sure, but obviously we don't do that to humans.
No, thankfully.
Yeah.
It took over a century to find ways to do this without, inserting tubes directly into people's arteries.
Right.
In 1881, an Austrian physician named von Basch invented a method using a water-filled bag pressed against the wrist. Then in 1896, an Italian physician, Scipione Rivarocci, introduced the inflatable arm cuff connected to a mercury column.
Okay, so that sounds closer to what we use today.
It is, but Rivarocci's cuff could only detect that top number, the systolic pressure,
Oh, really? Why?
because the doctor had to physically feel when the pulse in the wrist disappeared as the cuff inflated. It was completely tactile.
But we need both the top and bottom numbers to understand the whole cardiac cycle. So where did the diastolic measurement come from?
The missing piece finally arrived in 1905 from a Russian surgeon named Nikolai Korotkov.
Okay.
He realized that if you placed a stethoscope over the brachial artery, just below the inflatable cuff, you could hear a very specific sequence of sounds as the pressure was slowly released.
Ah, okay.
Right. So as the cuff deflates, the precise moment the blood finally pushes through the pinched artery, you hear the sharp tapping. That's your systolic pressure.
The big squeeze breaking through the cuff's pressure.
Exactly. Then the sounds turn into kind of a swishing noise, and the exact moment those sounds completely disappear, that's your diastolic pressure.
Yeah.
And we actually still call them Korotkov sounds today.
Wait a second. We have smartwatches that can record a live ECG. We have MRI machines that can map out the neural pathways of the brain in real time. But in modern medicine, our gold standard for this absolutely vital cardiovascular metric is still a technique from 1905 where a person listens for thumps through a stethoscope.
Pretty much, yeah.
I mean, with all our advanced technology, are there not constant failures in something as basic and analog as a Velcro arm cuff?
Oh, there are constant failures. I mean, the sources detail this issue of cuff error, And it is a massive, massive problem in daily medical practice.
Really? Like how bad?
Well, improper cuff size alone, just the size of the cuff, can shift a blood pressure reading by 10 to 30 millimeters of mercury.
30 points. How does the wrong size cuff physically alter the reading by 30 points? What is the actual mechanism there?
Okay, so think about it. If a standard-sized adult cuff is used on an obese patient, which, by the way, is incredibly common in busy clinics, the cuff is simply too small to wrap properly. When the machine inflates it, the air pressure in the cuff is basically wasted trying to compress a thick layer of fat tissue before that pressure even reaches the artery deep inside.
Oh, I see.
So the gauge on the machine is registering the high amount of pressure needed to squish the fat rather than the actual pressure inside the artery itself. It systematically overestimates the patient's blood pressure.
So a perfectly healthy person could be diagnosed with hypertension and put on heavy medication entirely because the clinic just used a cuff that was too small.
Yes, it happens all the time.
That's insane. And what if a cuff is too large, like for a very thin arm?
Then it does the exact opposite.
Yeah.
It underestimates the pressure because it easily pinches the artery with very little air pressure, so it can artificially lower the reading, potentially masking a dangerous condition.
Wow.
And cuff size is really just one variable. If a nurse measures over thick clothing, that skews the numbers. If the patient is talking during the measurement, that alone can raise the reading by 10 points.
Just talking.
Just talking.
I actually tend to sit with my legs crossed on the exam table when I'm waiting. The sources say that throws off the reading too, right?
It does, yeah.
But why would crossing my legs change the blood pressure in my arm? That doesn't seem connected.
It's all connected. When you cross your legs, you are physically compressing the large veins in your lower body. That physically forces more blood back up into the central circulation.
Oh, increasing the volume.
Right. It increases the volume of blood the heart has to suddenly pump, which temporarily raises your systolic pressure by several points.
That is wild.
Yeah. And even if your arm is not supported, like if it's just hanging below heart level, gravity causes blood to pool in the arm, which changes the local pressure. Or, if the clinician deflates the cuff too quickly, they will easily just miss the exact moment those Korotkov sounds start and stop.
So it's very operator dependent.
Extremely. Correct measurement technique is a critical patient safety issue in nursing education because, physical measurement error can lead to a completely incorrect medical diagnosis.
So if a chatty patient or a small cuff can change the numbers by 30 points, it kind of makes you wonder about the numbers themselves. The sources show that the medical establishment's definition of a normal blood pressure is entirely a moving target.
Oh, absolutely. It has shifted drastically over the years. For most of the 20th century, the prevailing medical consensus was actually that high blood pressure was just a natural, benign response to aging.
Benign? Really?
Yeah, textbooks literally taught a rule. Your acceptable systolic pressure was 100 plus your age.
Okay, so a 70-year-old running a systolic of 170 was considered perfectly healthy.
Exactly. The belief at the time was that the human body actively needed that extra pressure to successfully push blood through aging, stiffened arteries.
Which I guess explains the incredible historical data the sources have on President Franklin D. Roosevelt.
Oh yeah, his numbers were shocking by today's standards.
The sources mention his blood pressure was routinely recorded at these astonishing levels, as high as 300 over 190, and his physicians mostly just treated him with rest and mild sedatives.
Right. They simply did not view hypertension as a primary threat. It wasn't until the Framingham Heart Study, launched in 1948, that researchers tracked thousands of people over decades and finally proved that chronic high blood pressure was a direct causal link to heart disease, stroke, and heart failure.
So it completely overturned that 100-plus-year age rule.
Completely. It proved hypertension wasn't a symptom of aging, it was a disease itself.
But those guidelines are still shifting today, right? Look at the 2017 guideline change. The American College of Cardiology and the American Heart Association lowered the threshold for diagnosing hypertension from 140 over 90 down to 130 over 80.
That was a huge shift.
Right. So if you, or maybe your parents, went to the doctor in 2016 versus 2018, you could have walked out of the clinic with a brand new medical condition, hypertension, without a single physiological change happening in your body.
Right, just because the textbook changed.
Exactly. So are we risking overtreating people by constantly lowering the bar for what we consider a disease?
That is arguably the single most consequential debate in cardiovascular medicine right now.
Really?
Oh yeah. The core question everyone is asking is, how low should we go?
Mm,
Because blood pressure categories are not these biological cliffs where damage suddenly begins at a specific magic number.
right, it's not a light switch.
Exactly. They are statistical boxes drawn on a continuous curve of risk. The truth is, the risk of arterial damage actually starts rising well below 120/80.
Wow, okay.
The label of hypertension is really just the statistical point where experts judge that the long-term benefits of starting medication outweigh the costs and side effects.
So what actually drove the controversy over dropping that threshold down to 130/80?
Well, it primarily comes down to two major conflicting clinical trials. In 2015, you had the SPRINT trial, and it pushed for really intensive blood pressure targets, aiming to get older adults under 120 systolic.
And did it work?
It was highly successful at reducing cardiovascular death. In fact, they stopped the trial early because the data was so overwhelmingly strong, it felt unethical to withhold the intensive treatment from the control group.
Oh, wow. So that seems definitive.
You'd think so. But in 2010, there was the ACCORD trial, which tested intensive control specifically on diabetics, and they found no major reduction in cardiovascular events, but they did see a big increase in side effects from the heavy medication load.
But wait, the sources mentioned the SPRINT trial had a very specific measurement protocol, right? Something that didn't mirror real-world clinics at all.
You hit the nail on the head. SPRINT used a rigorous, automated measurement protocol.
What does that mean in practice?
It meant the patient rested completely alone in a perfectly quiet room for 5 minutes. No talking, no stress. And then an automated machine took the reading without a doctor or nurse even present in the room.
Okay, well, that perfectly quiet, isolated environment is naturally going to produce a reading that is, what, 5 to 10 points lower than what you would get in a busy, stressful clinical environment.
Exactly. So here is the danger. If a regular, chaotic clinic tries to aggressively hit that SPRINT target of 120, but they are using flawed manual measurement techniques on an anxious patient.
Then they are likely pushing the patient's actual resting blood pressure much, much lower than 120.
Right. And if you push frail, elderly patients too low with medication, you risk severe side effects like dizziness, fainting, falls, and even acute kidney injury from underperfusion.
Because the pressure isn't high enough to reach the organs.
Exactly.
So if we are aggressively pushing these numbers down to hit new targets, it seems like we're creating a massive blind spot. I mean, we're so culturally conditioned to fear the ceiling high blood pressure that we kind of forget the floor is just as dangerous. Lower is not always better.
It definitely isn't. Symptomatic hypotension, which is low blood pressure, is incredibly dangerous. And a very common form of this is orthostatic hypotension.
Orthostatic hypotension, what is the actual physical mechanism behind that?
So when you stand up from a seated or lying position, gravity immediately pulls a large volume of your blood down into your legs.
Right, just basic physics.
Normally, those baroreceptors we talked about earlier, they detect that sudden drop and instantly clamp down on your blood vessels to maintain pressure to the brain. Okay.
But in orthostatic hypotension, the nervous system is too slow or impaired to compensate in time. So the brain loses oxygen for a brief moment, causing severe dizziness or fainting. It is actually a leading cause of falls in older adults.
And at the absolute extreme end of that,
At the extreme, sustained low blood pressure leads to shock, which is a catastrophic failure to perfuse vital organs.
so to monitor this in critical situations, like say in the ICU, the sources say clinicians rely on mean arterial pressure, or MAP. But the formula for MAP seems a bit complex.
It can look a little intimidating on paper.
Yeah, it says it is the diastolic pressure plus 1/3 of the pulse pressure. And pulse pressure is just the numerical difference between the systolic and diastolic numbers, right?
Correct. So while the math seems complex, MAP simply represents the average perfusion pressure driving blood into the organs across the entire cardiac cycle. The golden rule in the ICU is that a patient's MAP must stay above 60 to 65 millimeters of mercury.
Okay, I think I get it. I think of MAP kind of like the average speed of a long road trip.
Oh, I like that. Right, because your systolic pressure is like the top speed you hit on the highway. Your diastolic pressure is when you are stopped at a red light.
Yeah.
So those are interesting data points, but your average speed over the whole trip, your MAP, is what ultimately determines if you actually reach your destination.
That's a great way to look at it.
Yeah.
And in this physiological scenario, the destination is keeping the organs alive. If a patient's MAP drops below 60, the physical reality is that the kidneys literally begin shutting down from oxygen starvation.
Wow.
The tissue actually begins to die completely, regardless of what the top or bottom numbers individually read.
It's all about that average. Hypertension is often called the silent killer, and it remains the largest modifiable contributor to global death and disability, precisely because you feel completely normal while your average speed is just slowly tearing up the plumbing of your heart and brain.
Yeah, you simply don't feel the damage occurring.
Yeah.
It's insidious. Furthermore, blood pressure naturally fluctuates throughout the day.
Oh.
A patient could have white coat hypertension, where their pressure is only high in the clinic simply because they're anxious about seeing the doctor.
I think a lot of people have that.
Oh, very common. Or they might have the opposite, masked hypertension, where their reading is perfectly normal in the clinic, but it's dangerously high when they're at home just going about their daily life.
Mask hypertension sounds particularly terrifying because it completely escapes detection during a routine checkup.
Which is exactly why modern guidelines heavily emphasize averaging multiple home readings over several days, rather than relying on a single clinical snapshot.
That makes a lot of sense.
Medical science is also shifting its focus in other ways. While we used to focus almost entirely on the diastolic number, we now recognize that the pulse pressure, that gap between the top and bottom numbers, is a key independent marker of arterial stiffness as we age.
So a widening pulse pressure means the pipes are physically losing their elasticity.
Exactly. They're getting stiff.
So what does this mean for you, the listener, the next time you are sitting on that crinkly exam paper? I mean, the journey we've taken through these sources reveals that blood pressure really isn't a single, unquestionable truth that a machine just prints out on a receipt.
Not at all.
It is a highly dynamic, ever-changing equation balancing your heart's output against your vessel's resistance. It is entirely reliant on very precise physical measurement techniques that, as we've learned, are heavily prone to error. And it is constantly being judged against a shifting statistical gradient of risk rather than some biological absolute.
Right. And understanding that critical difference between the literal pressure in the pipes and the actual delivery of oxygen to your tissues, that perfusion is really the fundamental key to making sense of cardiovascular health.
Absolutely. Well, to leave you with one final fascinating thought from our sources to ponder, we've talked extensively about the wild errors caused by the wrong cuff size or talking or even crossing your legs.
Yeah.
But blood pressure is so inherently variable that it can actually differ depending on which arm the nurse decides to use. It's true.
If one arm has minor plaque buildup in, say, the subclavian artery, the reading on that specific side will be lower. In fact, a difference of more than 10 to 15 millimeters of mercury between your left arm and your right arm isn't just a machine error. It can be a clinically significant warning sign of cardiovascular disease all on its own.
Yeah, it's a huge red flag.
So the next time they wrap that Velcro around your arm and squeeze well, you might just wonder what the other arm has to say.